Hello, my name is Jeremy Schmoyer, and I am a first year internal medicine resident at Verde Valley Medical Center. Today, I'll be presenting a case report about malignant ascites from a CD5 negative mantle cell lymphoma with concurrent Listeria Peritonitis and an immunocompromised patient. CD5 negative mantle cell lymphoma is one of the mature B cell non Hodgkin lymphoma that comprises about 7% of adult cases in the United States and Europe. The incident rate is approximately 4 to 8 cases / million persons per year, and about 3/4 of the patients are male. In the United States, 85% of ascites is due to transitive causes, for example, from cirrhosis or portal hypertension, whereas malignant ascites only accounts for approximately 7 to 10% of patients. The spontaneous bacterial peritonitis diagnosis criteria includes a PMN count of at least 250 cells, positive fluid cultures, and no intra-abdominal surgically treatable source of infection. Of note, SBP is commonly caused by E. coli, Klebsiella, and Streptococcus, with Listeria peritonitis only having approximately 128 cases reported worldwide. Some of the pertinent physical exam findings and labs for this patient included vital signs. She was afebrile, hemodynamically stable with some tachycardia. She had a respiratory rate of 20 with an oxygen saturation of 95% on room air. Her only pertinent exam finding was for the abdominal exam. She was severely descendant, firm, with dullness to percussion. You could easily palpate her spleen. She had no rebound tenderness or guarding. She had positive bowel sounds and a positive fluid waves. On her CBC, her white count was 73 with an absolute lymphocyte auto of 65. Her serum albumin was 3.2, and then she also had a paracentesis that showed a fluid analysis of cloudy with brown coloration, a WBC of 79,449. Lymphocytes percent was 88 with an albumin of 1.8. Of note, her SAG score was greater than 1.1, suggestive of portal hypertension. She also had blood cultures drawn that eventually resulted as gram-positive rods with final results showing Listeria, and she had positive fluid cultures for Listeria as well. Of note, her cytology for her paracentesis and bone marrow showed a B-cell lymphoproliferative disorder. On this next slide, I wanted to show the CT abdomen and pelvis with contrast that the patient received. In images A and B, you can note the massive splenomegaly measuring about 23 centimeters on the longitudinal axis, with some edema located around the spleen as well. You can also see the hepatomegaly this patient was experiencing, measuring about 22 centimeters. And then in image C, you can see this new severe retroperitoneal adenopathy with a pericaval node measuring about 3.4 centimeters in diameter. You can also note in the image that along the side wall, you can see enlarged pelvic lymph nodes. So a little bit about the patient's hospital course and management. She was originally admitted for blast crisis and peritoneal carcinomatosis, declining transfer request. On her first day of admission, the patient was having a symptomatic anemia of 8.6 requiring a transfusion. However, she needed irradiated blood due to her diagnosis of AMML. If she was a candidate for a bone marrow transplant, this type of blood would decrease the risk of her suffering from graft versus host disease. However, this would take a day for the blood to be delivered, which this delay allowed for her blood cultures to come back positive. And then eventually when sensitivities and Listeria grew, the patient was started on a combination therapy of gentamicin Q8 hours and ampicillin Q4 hours. The patient tolerated the therapy very well and eventually had negative blood cultures, allowing for a PICC line to be placed. After this, our ID specialist recommended a 4-week course of antibiotics. Over the next 3 weeks, however, the patient required multiple paracentesis. She even had a hospital readmission where she noted to have growing lymphadenopathy of the cervical region and axillary nodes. During this time, her official path report resulted as CD5 negative mantle cell lymphoma. So on week 4, due to the decompensation the patient was experiencing. She was started on her rituximab therapy to help prevent any more progression of her disease. By the end of week 4, the patient completed her antibiotic therapy, ampicillin, with no complications. For discussion, Listeria is a gram-positive intracellular facultative anaerobe that is a rod bacteria with catalase-positive activity and beta hemolytic characteristics on blood agar. It is primarily found within the soil and decayed vegetables. However, there are cases of isolated Listeria from water sewage and asymptomatic humans. It accounts for less than 1% of reported bacterial foodborne infections. A retrospective study from 1992 to 2017 reported about 8 cases of bacterial peritonitis, and the etiologies of this peritonitis was thought to be secondary to patients with past medical history of cirrhosis, CKD with a peritoneal catheter, and metastatic breast cancer. Of note, malignant ascites from CD5 negative mantle cell with splenomegaly-induced portal hypertension leading to Listeria SBP has not been reported after extensive literature review on PubMed. In conclusion, Listeria causing spontaneous bacterial peritonitis is very rare. A case report with Listeria peritonitis and CD5 negative mantle cell causing splenomegaly leading to portal hypertension, putting the patient at increased risk for translocation of certain bacteria, has not been reported. Of note, the mortality rate found for isolated bacteremia of Listeria was noted to be 45% within 3 months, and also about 30% for peritonitis. Our patient completed the initial course of ampicillin and gentamicin synergistic therapy and a 4-week course of ampicillin with no complications. And the patient currently today is receiving rituximab for her CD5 negative mantle cell lymphoma. On this slide, you can see the references used throughout my presentation. And lastly, I would like to thank you for the opportunity to allow me to present my case report and for taking the time to listen to my presentation.